It's now my pleasure to introduce Dr. Kate Johnston. She's an internist at the Women's Health Associates at the Mass General, and she'll be speaking to us on cancer screening in women at age 50 and beyond. Thanks so much, Kate.
Thank you. That was a lot to follow. I hope you can get something at this next level. My talk today focuses on screening for cancer. And I really hope that by the end of it, I will not expect for you to remember much about the details of what we do, when we do it, but I really think it's important to get a way to wrap your mind around thinking of how do we make screening decisions? What does it mean to do screening, and what are your doctors working with you to try and figure out? These are really important conversations taking place, and often people come to me and say, well, I read that headline that mammograms are no good anymore, and didn't you hear about this? There's so much in that to unpack and discuss, but if you understand the basic concepts of what screening is and what we're trying to do, I think it will really help you teach your family and friends and work with your doctors to partner on improving your health long term. So again, by the end of this, I hope that you'll understand some of the concepts of screening that your physicians are working through when they're talking with you at perhaps your annual exam, that we'll discuss what the guidelines are and how we think about using guidelines as a tool, and then we'll work through some examples. So screening is simply a strategy. It's something we do in many ways to look at people who have no symptoms at all and identify if they have an important disease or issue that we think we can do something about to help them live better or a higher quality life or a longer life. Specifically, when we're looking at cancer, screening is one way of reducing death and morbidity from cancer. Morbidity is the complications or the things that can happen with the treatments. Cancer causes 1 in 4 deaths in the US, and screening is only one approach. I wish I could tell you all the answers in prevention and about the wonderful treatments we have for so many cancers. But for screening, it doesn't answer everything, but it is an important aspect of health. Often when I'm talking about screening or talking with someone who has had a cancer diagnosis, many people's first reaction is, why wasn't this looked at, or why wasn't that found early? My family member has this cancer and there's no screening. Why not? Screening can't be done for everything. It requires lots of research in finding the right strategies and tools, and it is best applied to large populations. And we wish we could find it in everyone, and perhaps one day when we understand more about cancers, we will. But looking at having every test done or seeing your doctor to have a head-to-toe body CT or MRI exam is going to bring up so much more risk and consequence for your life and well-being that, if well-informed, most of us would never choose it for someone that we love. So when we're looking at screening as an issue, there are certain ideals we look at. And I apologize, this does have some medical jargon, but I'm going to use it as a touching stone. Specifically, we look at diseases that are relatively prevalent. Again, if a cancer only affects 200 people per year, it's going to be profoundly difficult for us to study it. We want to make sure that the testing or whatever type of strategy we're applying is acceptable to patients, that it's something a person would be willing to go through. And every person has a different definition of what acceptable is. We also want to know that our strategy will capture everyone that has that condition, and that in the group we capture, that what we find as being positive will really be for the condition of cancer that we care about. We don't want to be sorting through and missorting or having false positives or false negatives. And these events occur with every type of cancer screening strategy you will hear about. We also want to know that for whatever cancer we're looking at, that early detection with our screening tool will actually lead to a better outcome later for that person or that population. If we have phenomenal prevention strategies and we can prevent it 90% of the time, then we may not need screening. Similarly, if we find that our treatments for a particular cancer become so exceptional that 90 to 95% of people affected by it are cured by the treatment, then it doesn't matter when we find it. We could have people presenting very late stage and still be cured. Those are reasons why sometimes in the media, stories will be mentioned or news reports will talk about studies that show no benefit to screening in a specific way or in a specific population. Notably with breast cancer, the average breast cancer, the treatments have become very, very good over the past decades. And so when we look at using tests to find breast cancer early and saving lives through the use of that test detecting it early, we lose any effect that happens from the screening test when our treatments are so good that women could skip all screening and present and have their cancer well managed. That's in theory. I know that there are very many specifics with each condition. Another aspect that we look at is that the disease we're treating or the cancer that we're applying a screening test to really needs to be consistent, that it needs to be one homogeneous thing that we're applying our test to so we can be right about it being detected and therefore that we can take action and lead to a better outcome. With regard to breast cancer, prostate cancer, we're learning so much about the makeup of those cells that we're finding it's not all the same. One woman's breast cancer may be completely different than the type of breast cancer another woman has. And so far, we believe there's probably at least 4 different types. And we're only learning that when we study the tumors on a micro level. So when we apply a screening study and say, looking at a population of 50,000 women, who has their cancer detected really well by a mammogram in a way that we save their life later because they had their mammograms, if the cancers are all different levels of aggressiveness, different levels of indolence where they may never, ever grow or come to fruition, the results of that study, mixing all those different things together, is going to be very difficult to interpret and perhaps could lead us to see that it's not as beneficial or that we should use it in a different way. We also have to think about costs. So when I wear my public health hat, always we have to think about what do we really want, where do we want to spend our money. I believe there's a lot of money to spend in our country to improve the health and well-being in the lives of everyone. Specifically when we look at cancer, our screening test, we have to think about not only the test itself. I remember my mom always saying, I love getting my mammogram. I pay $40 when I go here. That was many years ago. But we know that it's not one test. There are many steps downstream. If you screen positive, you might have another series of tests. You might have a biopsy. You might have more. And the costs are financial, and they're also a burden. They're time off work. I have many wonderful patients that say, yes, I would do a colonoscopy test, but I can't take the time off of work, and I can't do the preparation, and I don't have anyone that can drive me home after I've been sedated. Those are huge burdens that are more than financial, that have to be considered when we're looking for the best way to save lives with a particular cancer in mind. Lastly, I'm just mentioning briefly, when we look at economic analyses, our economist colleagues often look at what's called equality. And that's just an analysis that looks at the value of a test, the value of the strategy, all the testing, all the money, and how much it saves a person's life and where in their lifespan it's saving someone. So a low-cost test or a low-cost or highly valuable screening strategy, for example, is pediatric or newborn screening. We find diseases when babies are born. We can take action that allows them to live nearly normal lives and normal lifespans. That's a very low cost for a huge impact financially on our society. Similarly, if there was a theoretical cancer that only affected people in their very later years, maybe only saving a couple years of their life, in theory, the tests of that cancer, the costs of that treatment, the amount of years of life saved, and where a person is in their lifespan at that time is going to appear much more expensive. So just in case you're reading, most of my patients bring in articles for me from the newspaper, and in case you see this mentioned, you'll at least have heard of it before. So I really wish, as a primary care doctor, I could say that I am constantly reviewing the databases of every medical study put out there by cancer, and I'm not. I very much rely upon guidelines. Guidelines are tools. They help us. They need to be used correctly, though, and they are not simple. Guidelines are merely a statement by which to determine a course of action. They aim to streamline processes. They are, by definition, never mandatory, never binding or enforced. They are full of nuances, and they can be issued by any organization, any group. I tend to look at guidelines that represent the groups to which I belong, the groups which share my values. American College of Physicians, internal medicines. I'm an internist by training. I look at what the American College of Obstetrics and Gynecology recommends because I do extreme amounts of women's health. I also look at American Family Physicians. I look at many different guidelines. American Cancer Society I care very much about. But the way they're written and that data they analyze and their perspective is going to be affected by their perspective. They are useful tools, but there are reasons why American College of Physicians or the United States Preventive Services Task Force might have a different guideline than the American College of Radiology or the American Cancer Society. How we use the tool and why we may or may not apply a guideline to a person in front of us is going to vary based on our background, our experience, and the values of the person in front of us in the office. When we talk about screening, I truly believe one of the most fundamental aspects of healthcare in preventing cancer and screening for cancer in appropriate people stems from a very good family history. I cannot underscore this enough. I think it is so important for all of us to know the history of our family members and to report that to our medical providers. This is information that's critical to your health and well-being that may affect how your medical provider thinks about your care, and it is dynamic. It is always changing. Even though I type it into one particular field of your chart, I have to remember to go back to it. I have to remember to ask, what else is new? Who did you see at Thanksgiving? Does anyone else have cancer? Specifically, when we look at genetic risks and cancer history, we very much care about what's called 3 generations. Your grandparents, parents, aunts and uncles, children, siblings, and first cousins. We care about that many people on both your maternal and paternal side. Both are equal and important. And so knowing what has gone on with those family members and reporting it to your doctor so that they write it down is an important aspect of your doctor being able to set a plan for your health and cancer risk reduction. I'm often finding new information and saying, I didn't know that about you. Guess what? I want to change our original plan. We aren't going to do your mammogram at 40. We actually do need to do it early because of that new history with that family member that has just come up and that I didn't know about you before. It's always changing and important. A number of years ago, our U.S. Surgeon General created a website for people to use and named Thanksgiving Day Family History Day in our country. I think it's a nice thing to talk about and to bring it up, and there are many tools and ways that families and siblings can talk and go online if they're comfortable with that medium and enter information and be able to reference it and have your doctor pull it up during a visit or print it out so that you can review it with your medical provider. Okay, so now we're going to walk through some cases. First is breast cancer screening. So we have a 50-year-old woman coming in for a physical. She feels fine. She has no specific concerns, but she did hear that mammograms shouldn't really be done as often. That's how she interpreted it. And now she's wondering, should she think about getting a mammogram because she's seeing her friends affected by breast cancer? What is the evidence? Over 230,000 women get breast cancer diagnoses every year. Over 40,000 women die. It touches many of our lives. It's awful and horrific. Even when it's cured, women live a long time with side effects of the treatment. We want to stop this disease, and if it's going to happen in an individual, we want to catch it as early as possible. But looking at the data we currently have, the mammogram test is not outstanding for finding breast cancers. There are many limitations. There are ways in which it could miss a cancer, or it could miss some of the more aggressive cancers that affect young women. All of this affects how we look at the data and see a benefit for how well a test could save someone's life. Specifically with mammograms, we see what we call a relative risk reduction of about 14 or 15%. So you're 14 or 15% less likely to die of breast cancer if you get mammograms in your 50s. However, when we look at the population, I find I may have to have 1,500 women get a mammogram to save one woman's life. That's many, many women going for a test who will never benefit from it, but we don't know who those individuals are. And it's incredibly important to find that one and help her. When we look at the guidelines, specifically for women in their 50s, the United States Preventive Service Task Force, which is a division of our Agency for Health Research Quality from Health and Human Services, they've looked at the data and they feel the greatest cost benefit is in favor of doing it every 2 years for women in their 50s. However, different providers may work with patients and make a different decision based on your individual needs. Mammography has risks: pain, false positives, the anxiety that comes from waiting for a result or hearing about a false positive or a scare is terrible. And the amount of benefit on how much that might save your life or lead you to have a higher quality life is small. So this patient, she gets her mammogram. She then hears that she's got high breast density. Breast density is something that's now being reported, and it is a very important factor on how we interpret mammograms. It is now law in the state of Massachusetts that it be reported, and I'm very happy about that because I always want to know how well the mammogram shows things for my patients. Overall, we know mammography has benefits. False positives occur with anxiety. Some women will die of breast cancer despite having screening. Most women will live even without having screening done. Overdiagnosis risk happens with all types of cancer screening, and family history really matters. And any woman that has a symptom should be talking to her provider and having that evaluated thoroughly until it resolves. I'm going to go a little quicker because I know I'm running out of time, but I hope to just touch on some of the concepts. So cervical cancer screening. Women understand that this happens usually through a pap test or a pap smear cervical cancer test. So a 53-year-old woman comes to our office. She hasn't had any screening in 5 years, and a pap smear is done. The result comes back a week later showing that the cells were normal, but that she has high-risk HPV found, type 16. What we know is that cervical cancer, despite all the screening we do, is diagnosed in about 13,000 women every year. Over 4,000 women die every year from cervical cancer. The majority of those cancers are caused by HPV, and the cytology test detects one type of cervical cancer. It's on the surface of the cervix. HPV testing with your pap smear improves detection because the same virus could be higher up in the cervix, damaging those cells, causing a cancer there. So when a person acquires HPV, it may never affect their body. Over 90% of types of HPV are completely cleared naturally by a woman's immune system. But in women who have it found on a Pap test, additional testing and surveillance is needed to ensure that her body clears it. The guidelines recommend Pap smear testing be done at least every 3 years and can be extended to every 5 with the addition of the HPV testing. And when a woman is found to have the HPV virus present persistently over time, it is recommended that she then see a GYN specialist who can do what's called a colposcopy test and have visualization of the cervix with a bright light and magnifying lens and allow them to see if there's additional changes and perhaps to do some biopsies to be sure that that virus is not damaging the cells. So I'm going to pause here, but I'm happy to take questions.
Just a few more minutes.
Okay.
We'll give you 2 more.
Okay. How fast can we do colon cancer? Okay.
And actually, Kyle will be covering this.
Thank you, no pressure. So we have a 55-year-old woman coming in for a physical. She's never had colon cancer screening. And she says, I know you're going to tell me to have a colonoscopy. I'm not doing it, but I just saw a commercial. There is a stool test, and I want that instead. I hear this every day. So what do we know? Colon cancer affects many people. The key take home, there are many options for screening. It's important to talk with your family, talk with your medical providers, choose what's right for you. There are certain tests we push harder than others, but something is better than nothing. Everyone should have some type of test to look for colon cancer when they are at least age 50, and earlier if they have family members that were affected at younger ages. And knowing that family history is really important to starting screening. This is a list of all the different ways in which we look for colon cancer. There are stool tests. So my patients that refuse to do anything, I convince them, please take these stool cards home, check your own stool and mail it back so I can look and see if there's microscopic blood. If there is, then we can order more testing. People who choose only that could be reducing their death from colon cancer by 30%. That's not insignificant. Something is better than nothing. There are also stool DNA tests that pick up the cancer DNA. These are very good tests, but they are not perfect. They are very expensive. Many versions of them are covered by Medicare for payment, but they are not well controlled and have much variability in how they are produced and the different companies that market them. And then the colonoscopy test, direct visualization. You have to prepare your colon and clean it out, to have the gastroenterologist look at it specifically with the camera when you are sedated. It is uncomfortable and hard to do, but it allows for direct inspection. It is really important to have tests that let you do that much and to see the tissue levels, because they can remove precancerous or polyps or early cancers right then and there. So you can wake up from the test and hear that something was found, but that now it's removed and they feel that they got it all, and the pathologist will tell us in a week or so what it was. And then you can set a better strategy for the future. But no test is fallible. There are cancers missed even on colonoscopy. They don't all appear the same way, and many women could have a colon that is what we call tortuous or bending, and it's very difficult to know for sure. So in any person that has symptoms or concerns, always talk with your doctor, because it's possible you might need other testing or another colonoscopy test even if you've had one 3 years ago. I think I'll stop there. Thank you.